Hello everyone and welcome back to our, I don't know what episode this is, fourth
Fifth?
episode?
Yeah.
Fifth? We have lost track. Fourth episode or fifth episode of our Infection Prevention and Control podcast. I am Fran, I'm one of the Infection Prevention and Control nurses.
Hi everyone, welcome back. My name's Jen. I'm one of the other Infection Prevention and Control nurses.
And also, quick one, Jen wanted us to say this, May the 4th be with you.
Oh yes,
because
that's
that is
very
the day
important.
that we are recording this on. So there we go. So today we're going to be talking about CPE, which is called Carbapenemase-producing Enterobacteriaceae.
Nice
And
one, Fran. She
yeah,
did
I was
it.
going to say, we have been struggling to pronounce that word, so I did it.
You did it, Fran. We've been working on pronunciation, guys, for way too long.
So we'll abbreviate it to CPE for the purpose of this podcast, but it's an
And the purposes of our sanity.
Exactly. But it's an example of a multi drug resistant organism, of which we are going to do actually a little sort of mini podcast series on.
Lucky you guys.
So I will hand over to Jen just to explain what the C and the P stand for in CPE.
Yeah, so hi everyone. We're going to just try and break it down simply because I think it is an organism that can cause quite a lot of confusion because we don't see a huge amount of it. So when we do suddenly have a patient come on the ward, we're told they have CPE, it's a bit of a sort of, what's this again? And we just wanted to have this available as a bit of a refresher to try to break it down a little bit into more sort of simplistic terms so that we all know what we're talking about because it's not that scary. It's just something that we need to sort of understand and work through together. So the C part is carbapenemase. The P is producing. So it's basically saying that this organism is producing carbapenemase. Now, what carbapenemase is an enzyme that this bacteria produces. And what that enzyme does is break down antibiotics. And when they're broken down, they are no longer working. It's making them essentially sort of ineffective. The P is produces, which I've already mentioned, and it's just saying that this bacteria produces carbapenemase and it then renders antibiotics basically ineffective. So carbapenems are a family of antibiotics. So carbapenem resistance is a problem globally that is increasing. It's making it harder and harder to treat. Therefore decreasing the ability for us to be able to find antibiotics to treat resistant organisms.
Okay. And what are carbapenems?
So carbapenems are a powerful group. They're one of our top tier groups of antibiotics that we use to treat infections. So they come from the B-lactam family of antibiotics and they're reserved to treat sort of really serious infections, predominantly caused by gram-negative bacteria, including Enterobacteriaceae. Oh, mind the pronunciation there.
Pretty much right.
In hospital settings. So some of these carbapenems, when they're prescribed, some examples are meropenem, ertapenem, imipenem, which I've never actually seen, or doripenem, which I also haven't seen. So I think the most common ones we use in this part of the world are meropenem and occasionally ertapenem. So what about this little bug is very concerning to us?
So it's a smart resistant organism in that it can share its genetic material with other organisms and therefore it could potentially spread the ability for its resistance. So this can occur across such a wide, different families of organisms. So it's obviously making it harder and harder to treat worldwide.
Yeah, it's one of those, it's something within the arsenal of bacteria that it can share all of those, nasty resistance bugs and it then becomes harder and harder to treat.
Absolutely. So the next letter is E. So here we go again with that word. So Enterobacteriaceae are effectively a large group of bacteria, but they're sometimes called coliform. So if you ever see that written down, that's what they are. And these can include things like Escherichia coli or E. coli, Klebsiella and Enterobacter species, which normally live in the gut and typically they don't cause any problems. But they can cause opportunistic infections of things like the urinary tract, intra-abdominal area, and the bloodstream when they get into that area of the body.
And this only really happens in people who are unwell,
Yes.
right?
Yeah, absolutely, yeah.
So if someone were to have like a simple chest or urine infection, it then might become really difficult or possibly impossible to treat.
Yeah, absolutely. And that's definitely the same with if patients are having just routine surgical procedures and they have CPE, it can become very difficult to treat.
And it's something that we need to be really mindful of. We need to have a really clear history on our patients, on if they've ever had a positive or if they've ever known to have been have an inpatient stay in another hospital. It's really important we have that information.
Absolutely.
So we then know where on the sort of the risk where they are in terms of risk.
Exactly. So get reading those notes, get quizzing your patients. We need to know where they've been.
Yeah. So the next part I have written down is colonization versus infection. This is the bit that can sometimes lead to, I think, a little bit of confusion.
Yeah.
But essentially, to be colonized with something can just mean that it's there, it's present. You might be colonized with CPE, you might be carrying it in your gut, but it's not necessarily causing you any problems whatsoever. Versus the infection is where it is systemically affecting you. It's affecting one or more of your organs and is causing you to become unwell. So sometimes people can be treated for a CPE infection. They then may remain colonized with it for potentially the rest of their life. It doesn't need to cause any, doesn't necessarily cause any future issues, but it's something that they need to be aware of. And it may be something that we never entirely get rid of.
Yeah, absolutely. I mean, yeah, on the lines of not being able to entirely get rid of something, our next sort of topic is how common is it? So CPE has become a global threat over the last decades because there have been outbreaks in healthcare facilities. So we, as Jen said earlier, in asking where patients have been, if they've been on holiday, if they've been in hospital in another country. So we're always asking if you could do screening for any patients that have been an inpatient in stays abroad and in Manchester and the UK. But typically the countries of the higher prevalence are places like Greece, India, Ireland, Israel, Italy, Japan, North Africa, Malta, the Middle East, Pakistan, Southeast Asia, South Central America, Turkey, Taiwan, USA and the UK, obviously, as we said. And yeah, some of the hotspots in the UK can be places like Manchester and London. So currently we are working on, we have a new policy, which is that all patients in the UK, if they've been an inpatient in a hospital in the UK, need to have a screen for CPE.
So we haven't quite finished that off just yet. It's in progress, and that is the national guidance. Our new policy is going to very likely echo that, but hold fire for the time being because we are still going by our CPE policy of old, if you like. And I feel like you've ruined a lot of holiday destinations in your where is CPE a hotspot.
I was going to say, it's a shame I'm going on holiday.
So how do we get CPE? How can somebody acquire it? So the way that it is transmitted is through direct and indirect contact. So touching items or surfaces in the immediate environment of somebody who is infected or colonized with CPE. One thing to add, just going back to colonization, is even if somebody is colonized with it, it doesn't mean that they can't transmit it. Yep. They may not be unwell with CPE, but they could still quite easily transmit it. And that's the reason that we will go back to in a minute. But that's the reason why we would still treat somebody who was colonized in the same way as if they were infected. Touching items or surfaces in the immediate environment. And that's why cleaning is such an important part of CPE. But before we get to cleaning...
Yes. So the big question is, how do we test for it? So what we need is to have a rectal swab, which is stained with feces, or we can have a fecal sample. If you've got concern on patient that has received healthcare, as I was saying previously, in any other setting, and you're just generally concerned or have questions, just give us a call. So our current guidance is that we have 3 swabs, 48 hours apart, and all of them need to be negative prior to stepping down their isolation. The type of swab or container that you need to use is a black swab or a blue stool container. And typically the lab turnaround takes about 2 to 4 days for a provisional result, and then it's got to be verified by one of the microbiologists. We don't retest for clearance. All we would recommend is that there is very clear documentation that when you're handing over to a care home that you have very clear communication on discharge, and just making sure that it's identified to them so there are no questions.
Yeah, and making sure it's just clearly documented everywhere so that everybody knows what we're dealing with. Isolation-wise, we know that isolation is quite often an issue for multiple different reasons within the trust, but somebody with CPE is an absolute must. I know we say that about most things, but CPE, we really, really mean it.
Please.
If you have any concerns over not being able to isolate somebody with CPE, please give us a call and we will move heaven and earth to find a side room for this patient.
Absolutely.
Whether they are colonised or infected, it doesn't matter. They need to be isolated for the entirety of their admission, preferably an ensuite side room. I know that we are asking a lot, but if we can't have an ensuite side room, could they please have a dedicated commode? Again, I know that can sometimes cause a bit of difficulty with patients, but with these resistant organisms, we have to try to prevent further transmission. If they have a dedicated commode, we just have to make sure that they are being cleaned after use and minimum of daily with our red sporicidal wipes.
Yes, definitely. And then PPE requirements for CPE. So your general, when you're entering into a room, is apron, gloves, ensure that you're changing your gloves in between tasks, and also ensuring that if you're doing personal or direct care with the patient, if there is a splash risk or you're doing cannulation, then you need to use a long-sleeved gown.
Yeah. So just popping in to give them maybe some oral medication or to do their OBS, that is fine to just wear our standard apron and gloves. If you're going in for any length of time, or you're going in to give them, for instance, a bed bath, or any of the things that Fran had mentioned, such as a splash risk, you need to make sure you up that PPE to have a long-sleeved gown. And we can get the long-sleeved gowns from PPE stores.
Yes.
Cleaning.
Our favourite.
So cleaning for CPE, we know that it is a hardy, virulent little so-and-so. And so what we recommend for cleaning is using the green wipes and the red wipes. I know. So the red wipes are our dry sporicidal wipes that need to be activated with water. They need to just be run under a cold tap and then give them a little sort of smush around. And in sort of 15 seconds, that wipe is ready to go. So when a patient is in the side room, those daily cleans need to be taking place and the cleaning of reusable equipment. When the patient is transferred out of that side room to another facility or they're being discharged, that room needs a red clean, please, folks. And in regards to cleaning, we are working very closely with domestic services following the implementation of the new standards of cleaning. We have a new national colour coding standard for cleaning areas. And so just as an example, the red is used for cleaning sort of sanitary ware and sinks within bathrooms, for instance. We just want to make sure that there is no sort of double dipping of cloths and thereby putting like a contaminated cloth back into your cleaning fluid. We need a clean cloth for each task.
And I guess just a little bit of self-promo. If you've got any, just want to listen to anything about cleaning or the wipes or anything, our first podcast episode back in March was actually very good for running over the actual use of all the wipes and the cleaning and everything. So check it out. And there's also a little bit on cleaning in our newsletter as well, which actually can be found on the internet, I believe. If it can't, I'll sort that out. So I suppose, like, the other thing, I mean, that was a very big rundown of effectively everything that CPE is, everything that we need to do. So we have, we do get a lot of questions, understandably. It is very hard to just wrap your head around in general. So, Jen, what kind of questions have you had when you've been out and about?
So, when we've done some teaching on the wards, we've had some really interesting, entirely valid questions that I at the time, I almost felt like I wasn't able to completely answer. And I thought, and I sort of came away from it And we've since looked into it. We've chatted through it with the team. And so I hope that this can help to provide some answers. But no question is a silly question. They are all entirely valid. And it was really helpful for us because it made us question some things. And we went back and spoke to our colleagues and did a bit of research ourselves. So one of the questions was, am I safe as a staff member? Entirely valid. We have to look out for ourselves. The answer is yes. Use your PPE and wash your hands. This is an opportunistic organism that affects people who are unwell. If you have a long-term medical condition or anything that you are uncomfortable with, speak to your line manager and let them know that there's something that you're not feeling comfortable about. Give us a call, just communicate and talk to us about it, and we can try to alleviate any concerns.
Exactly.
But are you safe as a staff member? Yes, you are.
Yeah.
Follow the PPE guidance and the hand hygiene guidance, and you will be A-OK.
It'll be absolutely fine.
What can we do to prevent CPE, Fran?
So to prevent CPE, like CPE, like other organisms, they like to stick to things like non-organic materials. So things like catheters, PVCs, drains. So it's vital that we look at patients and try to remove any unnecessary invasive devices. And if you know that they do need them, and it's been specified that they do need them, then obviously we would just really encourage documenting them at least minimum of once daily, ideally once a shift on EPR. And that just helps every staff group sort of know that they're being checked regularly. We're ensuring the safety of our patients and then ensuring things like CPE don't occur.
Certainly trying to be kept to a minimum as much as possible.
Exactly. And again, if you need any help with the EPR side of things, then obviously you can contact the EPR team regarding that if there's anything that you're confused about.
And I think a lot of our patients have invasive devices in, and it's sometimes just thought, well, that needs to stay in.
Yeah.
A lot of the time it doesn't.
Yeah.
A lot of the time you see people with these cannulas in that have been in 3, 4, 5, 6 days plus, and a lot of the time they can come out. So if you're not sure, speak to the nurse in charge, speak to the doctors, find out if you can just whip that invasive device out, nicely and gently, of course.
Yeah.
And the same goes with sort of things like long-term catheters.
Yeah.
Hopefully patients would have brought in any catheter passports and stuff like that.
Yeah.
But it's making sure that these things are documented in and that they're then being sent back out to the community with them, so that everybody is on the same card with when it was put in, does it need to stay in, etc.
Yeah, we're just obviously, like everybody is, trying to really enhance and put out there that clear, concise, effective and communication, which is very much needed in a lot of situations. So yes, if you can do that, that would be amazing.
So visitors.
Yes.
Another really good question I had when I was doing some teaching, and entirely valid, was we have all these precautions when they're in a healthcare facility, and then once they're sort of systemically better and they're no longer infected, they go home and there's no further precautions. One thing that we would like to say to reassure members of staff and thereby their family is that this is an opportunistic infection. It doesn't have to it doesn't necessarily cause problems in everybody. It is, if you are a healthy individual, there's no reason this is going to cause any problems for you. We would just obviously advise continuing with good hygiene practices at home. And if you have any concerns over your medical condition, to sort of seek assistance. And it's really important to, if patients or relatives are presenting to a healthcare facility, to let them know that they have had they've previously been positive for CPE, or that they live with somebody who's been previously positive for CPE.
Absolutely. And obviously we get all of these results through to our separate system, and we always endeavour to, and we're going to, I think we do it for every patient actually, is that any patient with, say, a CPE or, any multi-drug resistant organism, we always come round with a patient advice leaflet, and we will leave it with them, and then in the back of that, it actually encourages them to bring it back in so they can show, whether they're an inpatient or outpatient, so they can show the member of staff that they're seeing that they have previously had a multi-drug resistant organism, just so we can make it a little bit more aware, everyone a bit more aware, and then it's also on the system. So, I mean, yes, there are a number of different abbreviations and words used to define CPE and MDROs. And I think a lot of the time it can just get incredibly confusing. And if you're unclear or unsure on a diagnosis or a history of your patient, just reach out to us, reach out to the microbiologist for any further advice.
Yeah.
It can get confusing. We completely understand that.
Yeah. There's sometimes lots of different abbreviations and so on for what essentially means, if not the same, a very similar thing.
Yeah.
So reach out to us and
Yes.
we'll try and demystify if at all possible.
Yeah. So I think hopefully that wasn't too much too confusing. As I said, that is just one episode of our mini series of MDROs that we're going to be discussing.
And just to reiterate, multi drug resistant organisms. We are
Yes.
terrible for abbreviations.
I'm so sorry.
And so we're going to do a little mini series, as Fran said, on multi drug resistant organisms. So you'll have to wait and see what comes up next.
Mm-hmm. So I suppose, that is everything. So this is, our May episode. So we will see you for our June episode.
Yeah, thanks very much for listening, guys. And as always, any feedback is muchly appreciated, please. So if there's anything you would like to hear about, / we're chatting too much, / it's not relevant, please let us know.
And as always, if you ever have any queries, you can contact the infection control team on extension 6122 for Gloucester or extension 3129 for Cheltenham.
Thanks very much.
Thank
Bye.
you. Bye.